Great. Thanks for another week of hearing my updates. No news on any new papers as far as I know from our group. Hopefully this paper here, the mitochondrial paper will be accepted soon, but we'll give more updates during our mitochondrial meeting.
I'm
Um,
I'm doubtful.
yeah, I know. Yeah. What So some updates here. Just again, we have the case reports that Al's been leading for some unique long COVID cases. If people want to join those, let us know. But let's just dive into the new papers, news. You might have heard some of the COVID news that was in today and yesterday was about FDA advisors saying, that it's not probably no surprise to anyone here that the COVID vaccines for the fall should be updated to match the new XBB variants that are popping up, and they're recommending people should get the boosters if when that happens. But here's some papers related with treatments and shots. This one paper came out, and I'm going to go over a couple other things related to this. Adintrevimab. Can't pronounce it. Adintrevimab. There you go. Almost a tongue twister for me. But yeah. So this is a kind of it's based on an antibody for this, and this treatment that they're giving is basically looking like a monoclonal antibody that seems to be acting as sort of a preventative in a sense, when they give it in this random trial. Here's some description about the trial. Some more description about it is this one company has been developing this. Basically it's a human immunoglobulin G1 monoclonal antibody. And there's some of the papers that came out earlier this year talking about the efficacy, like seems fairly safe, testing on various cohorts. And in hamster studies they've done to show that it seems to have some benefits. And in this newest study, they went across different countries and different sites, and there seemed to be a robust number of participants in these sites, and they showed that through PCR confirmation that the infections from the primary, people who got infected with the primary point, with like Omicron, for example, they seem to be having a very beneficial, as you can see, maybe these figures are kind of small here, but like this lower figure, for example, the greenish color is with the this adintrevimab, and the placebo is in the blue, and these are the people who got infected. The recovery, whether they were able to recover from that infection or not. And then this other figure here showing the beneficial favoring this monoclonal antibody treatment. So it seems to be promising. I guess they're on clinical trials now, but this could be a potential. One thing they didn't do in their cohort, they took out people who are already vaccinated or had some of these other treatments, because they're looking purely on I guess people who are getting their infections without any other possible vaccines or treatments to be involved.
Afshin, did they say what the antibody was to what part of the virus?
It's for a human immunoglobulin G1 monoclonal antibody, and I didn't read. They do in this paper here, the hamster one, but I didn't actually read in depth to figure that out. So I'll have to read that and get back to you on that.
So,
Sorry, I don't have more information. Yeah, sorry, Kevin, go ahead.
so they tested this in human patients, not just animal models.
Right. That was the latest stuff they did from May
Yeah.
to now.
Did they describe any significant difference of effectiveness between demographic groups like sex, gender, education, socioeconomic class, that sort of thing?
Yeah, and in this paper, they went through gender. The one that just came out this past week was gender, age, and race, because they went across different countries, 8 different nations across 88 different sites, and they didn't see a difference between the
Okay.
treatment.
Yeah.
Socioeconomic, I don't think they covered, but I guess you could try to imply based on the regions they looked at. But yeah, I got to read more about this. So to answer Doug's question fully, but and it's accompanied by this company here in Vivid in Waltham, Massachusetts, is the one that's developing this. So it seems promising. Here's another, actually, a review that came out this past week. Maybe the inflammation group might be, since the paper they're working on might be interested in looking this review over, because it does a nice job going over talking about the role of immunity, your natural immunity, and how that might play into severity and infection and so on. So we went over like the current literature and what is known with and without the vaccine, and you get the immunity, and then it's kind of a good comprehensive viewpoint about, let's say, T cell responses they have in this figure, or other inflammatory factors that are related with lymphocytes and myeloid cells. But this is a review if people wanted to see what's there, and it seemed to be pretty good up to date, talking about different age groups, genetics, and so on. Here's a microRNA related paper, since you know, most people here know I'm interested in microRNAs, but this is probably the first pretty good comprehensive microRNA paper in patients with COVID. So what they did here was they looked at patients across from, I think this was, I forget where they're from, I think from Saudi Arabia or somewhere in the Middle East. So they looked at their cohort of patients there infected with COVID and not. And this little graphical abstract describes what they did. So they looked at people who were, under ICU admission or not admitted, with milder cases or severe cases. And then this is the numbers. They had 29 patients there, 67 there. So it's lower numbers, but still pretty good. So they took a whole saliva samples. At the whole saliva samples, they actually did microRNA sequencing and bulk RNA sequencing. So they had that data that's actually available to the public in the SRA. So this is something maybe people here might want to mine, because I would be interested in that. And then they also looked at the phenotype data, and then they also did looking at SNPs and then the viral load. So the SNPs they did some on the saliva, and the viral load they looked at the saliva patients. And then they compared it to the electronic health records. So it's a pretty neat study. They looked at 259 individuals total, and they had the controls, of course, COVID negative and so on. And then this little panel B describes like their symptoms and stuff. So basically what they did was, one thing they looked at was neutrophils, and I think Doug had mentioned in one of the meetings of it, how neutrophils can be potentially mitochondrial, maybe more related. Is that right, Doug?
Yes.
Yeah. So they went over, they did some specific analysis looking at the microRNAs that are dependent in the neutrophils versus the whole blood. And then they kind of categorized these microRNAs here versus lymphocytes and so on. And this is so this is one figure characterizing that. And this is the other figure. And one microRNA that actually popped out, which I might be interested in, Doug, is the 181A, which is the mitochondrial related one, which we've looked at too.
Was that,
and this
it looks like that's inversely related to virus, right?
Yeah, so exactly. So this sort of what kind of we're showing too when I quantified the microRNAs were suppressed, right, when the viral load was up. And what they did here, though, they looked at the expression related with the cis EQTLs. So they're just correlating where in the chromosome might fall, and then where might be related with the different changes in the alleles. And these were the three top hits that they figured out might be related, looking at the SNPs. Because they did the SNPs in the saliva, and they're related to that. They have some other details in this paper, but this is kind of a quick highlight. These are and as they say in the paper too, these are the three because they focused on neutrophils and the variations that might be related to the alleles and the viral load. But there's a bunch of other microRNAs in their data set that I'll be wanting to see what maybe 2392 is in there, but they weren't paying attention to it. But this was an interesting paper. It just came out about 5 days ago, or 4 days ago.
It's interesting that the odds ratio for 181 is one of the higher. Oh no, I guess 5189 is very high.
But it's the opposite of 181A. So 181A is the only one that's going this upward trend with the more number of minor alleles. I don't know what that means in the sense of what you know about it, Doug. But there's a lot of data here to mine too, because this is all of it's available, of course, publicly. They put it on SRA. So I don't know if Doug or someone, maybe Jeff, is interested in throwing this in his little pipeline he has that he could analyze the public database and then share the data with the group. That would be something we could play with.
I'll talk to him about it.
Yeah. Because I think this is one of the first data complete sets from humans that actually did the mRNA, the bulk RNA, and the microRNA. So now you can really relate what the targets are and how the targets are changing with the microRNAs, which is pretty neat with COVID. So this is a neat paper that came out 4 days ago. Some long COVID data. This was in the news about the study they did in Mass Eye and Ear here in the Boston area, where they estimated that they looked at EHR data here for this paper. This paper on the left side, on the this journal here. But basically, what they found in this paper is that that the majority, or that I forgot the percentages in here, but the majority of adults infected back in 2021 are never recovering back their full sense of taste or smell. Some more extreme than others, but that was the basic summary of this. They didn't go into biology, so they were looking at EHR data. So what biological pathways and things are affecting this, they didn't go into. This was another study they did looking at health record again. This is in Scotland. Looking at the long COVID Scotland study. I guess there's a big study there like that. But they looked at basically tracking individuals versus groups, and their argument here is maybe the individual variance is usually lost, or individual importance of how long COVID goes between people, or between, from the time you get infected to that, and the symptoms are kind of lost in the group analysis. So they did a nice individual variation, and then they determined some previous symptoms and how these might be changing between individual variants that would be there. Again, no biology, just purely health records. And this is a preprint, so take this with a grain of salt, but this actually has molecular data in it. This is proteomic data. So what they did here, which is, again, this I think the link in this paper for the proteomic is available, so this might be of interest to the inflammation group. And what they basically did is they looked at proteomic data from the blood from the patients, for the monocytes, and they basically did some pretty good job characterizing based on clinical data they had, the questionnaires they gave, what kind of long COVID symptoms they have, whether it's fatigue, depression, so on. And cardiac, they focus a lot of it on cardiac too, and gastro, and cognitive too. And then what from the proteomic data, they started figuring out in the summary figure, some of the key inflammatory proteins that are related to some of these factors that are being dominant in their blood floating around. So, for example, in the cardiac patients that reported long COVID cardiac issues, IL-1R2, MAT-N2, which I'm not familiar with MAT-N2, what that is, but the paper talks about it. And this other one is complement activation protein is dominant in those cardiovascular patients versus, let's say, if you go to gastrointestinal issues, this MAT-N2 seems to be popular everywhere from any long COVID patient, but there's some other key unique proteins that are popping up. And this is one of the figures from the paper where they're looking at the characterization and use of the proteins versus the different categories of long COVID patients, where they're cognitive, cardiac, fatigue, and then they go into specific details in each of these in the later figures. So it's a preprint, so take it with a grain of salt, but the data's there at least, and there seem to have some interesting key proteins that are popping up that overlap with what our inflammation group is doing in their paper. And the basic conclusion. Oh, sorry. Go ahead.
Well, Bill, is this data consistent with mitochondrial dysfunction in the brain and other,
They don't talk about mitochondrial. They didn't focus on that. A lot of people ignore that, as we know. So they only focus on inflammatory factors. But the data's there, so that means we can go in the data and say what are the key mitochondrial proteins that might be related and do the same kind of analysis as they categorized it.
Another issue is how they prepared the sample. Often they spin out the high molecular weight material before they do the analysis, and that would have sedimented all the mitochondrial proteins. So that often you see a bias against what you would normally expect to see in mitochondria. So that's another possibility.
Yeah, I haven't read the methods, so I guess we have to look that up and see. Yeah. But something to look into. I mean, their basic conclusion is that there's monocyte inflammation happening and complement activation. That was their take-home message from this paper. But as Bill's question and Doug pointed out, they didn't look at mitochondrial very well because of what Doug might have pointed out, or they just didn't pay attention to the mitochondrial proteins that are there. Whether they spun them out or not, I don't know. I have to read their methods. So that's the but that's the good thing about this paper. They did a good job with getting the patient data, so you can actually categorize things if we start diving into this data itself. Okay, I don't know if there's any questions on these papers. I went through them, or news, or comments. We'll come back to them. But the basic trends, the variance, we know the XBB.15 is going down, so the 1.16, 1.9 is the ones that are dominant. There are some new XBBs that we've heard of, 2.3, 2.33. These 2.1s are starting to pop up as a new variant. I forget where it's starting. Whether it's I think it's starting outside of the U.S. first, but I have to go back and look. But the point is, these ones seem to have not too different for your symptoms that are there. I don't see, maybe you would know this, but it's just some new variants that seem to have some growth advantage over the other ones that people are watching. I guess the good news in the U.S. is that, and I mentioned the rest of the world's following this trend, is still, when you look at the wastewater, that seems to be the most reliable way of looking at trends, what's happening. And this is from the last updated was June 15th, yesterday, from June 12th week, meaning this week. But you can see the trends are still going down, but now it's kind of gradually plateauing. Whether U.S. region is looking at where I live, you get these bumps going up and down. If you look at different counties, some counties are going up, but then they seem to go back down. So you just have to look on here for your county, and if they're collecting the wastewater and monitoring. And this is the sequencing. You can see that the XBB. This is a little behind because, as you see, it's May 29th since they're sequencing it. So it's always a few weeks lag, a couple of weeks lag. So I imagine when we hit this week, when they finally reported, you can see a lot more XBB 1.16 and 1.9 as we see in the CDC tracker here. And you can see this here that, again, that's not a surprise to anyone. XBB.15 is diminishing, and then these other 1.16, 1.9 is taking over, as we see in these parts of the regions. 2.3 is here, and you can see that is climbing steadily. It's that was this pink color on the bottom. So some people think this might take over this variant. There's some growth advantages. I haven't heard of anything about causing new symptoms or hospitalizations yet, but I guess we have to wait and see. If others know about it, you can tell me or speak up. And then, this is just the global trend looking at the cases, hospitalizations. Again, cases are not as reliable as we know these days, and the hospital admissions or ICUs are probably one of the better ways of looking at it, although if they're milder cases, we won't know the true cases in each of these countries. But
do you know which other countries basically have decided the pandemic is over and are not tracking, and which ones are still tracking?
I think most countries, like UK, they checked out a while back, before the US did. I think most countries are about the same. I mean, Japan and South Korea are still tracking pretty well from what I understand. But I don't know of any country that hasn't said the pandemic.
And do you know which other countries are monitoring wastewater?
There are. I mean, like Italy has done let's see if Adam's our wastewater person. But Adam's here. So Adam, I don't know if you can answer that question.
So we've seen a lot of ongoing efforts within the European Union. I know that Belgium right now has a national program that they're getting off the ground for a ddPCR analysis. A lot of the European Union is moving now into ddPCR, similar to the CDC, and moving away from the RT-qPCR for quantitative analysis of wastewater. But I think the majority of programs, the really robust programs that we're seeing are in North America, European Union, and Australia. There are, though, I'm working with a colleague in Malawi that they are getting together a wastewater monitoring platform. So they do have them in South Africa. I know China does have a program. I'm not sure how robust that is. I know Russia has been doing stuff. So, we see it across the world, virtually every continent aside from Antarctica. but the really robustly developed programs continue to be in the developed world, and we're only really starting to see application in the developing nations maybe over the last year and a half or so, and it's still nowhere near the quality that the United States or the European Union has really been able to develop.
I guess the next question for you is like the trackers. The trackers like BioBot does a good job in CDC, but it's hard for me to find other countries that have good trackers that people could access.
Adam, Bill, it might be incidental or off topic, but yesterday there was a report that FDA is looking at wastewater tracking for new drugs coming into the system because Schedule 1 drugs are now being cut with xylazine, a horse tranquilizer. Have you seen anything done with tracking drugs in wastewater?
Yeah, actually, I've done quite a bit of that. So that was the original focus of my doctoral work. Back prior to 2020, the focus of wastewater surveillance was quantification of narcotics and opioids within wastewater. So the city of Tempe, Arizona, actually has a really robust program set up. But now that COVID has kind of, it hasn't gone away, but the emergency use authorization has expired, and we're starting to see some movement away from the wastewater monitoring of COVID. There is becoming a renewed interest in looking at illicit narcotics and pharmaceuticals of abuse. The one I believe it was Virginia, Governor Youngkin put out an executive order that for opioids and fentanyl specifically, within that, one of the 4 major task items was development of a wastewater surveillance platform for fentanyl. In addition to that, the Biden administration recently published a emergency for fentanyl laced with xylazine. As you said, the street name for this is Trank. And we're starting to see, I believe in 2022, about 25% of the seized fentanyl powders by the DEA had positive detections for xylazine. I'm actually giving a webinar on this next Tuesday. If there's any interest, I can pop I could send you the link to the webinar registration. You can distribute it. But I'll be talking specifically about how we can use wastewater surveillance for narcotics and pharmaceuticals of abuse.
Yes, send me the link, and if you want to put it in the chat now too.
Yeah, I'd like to see it.
So one last question for Adam is: so do you get all this? Do you get strain data from the wastewater?
If we do sequencing, then yes. So we would use actually, hold on, let me back up. We can do it one of 2 ways. If you do kind of the a shotgun sequencing approach, it's still a developing aspect of wastewater surveillance, but you theoretically can get a full distribution of variants and also emerging variants that we might not have noted in clinical cases. But this is a very nascent part of the field. I would say the more robust aspect of variant surveillance is through in our laboratory, we do droplet digital PCR multiplexing. So we'll look for N gene, S gene, and then we have gene sequences for XBB, for BA5, BA4. So as we see them coming into the United States, and our threshold, we have a % threshold for the United States that basically, if we see it get above this rate, it's likely to become a dominant variant. So we'll develop the primer probe set sequences and the methods to add that to our multiplexing capability. So we're able to look for total SARS-CoV-2 and then also variant, quantitative variant amounts within the wastewater through that ddPCR process.
And currently, how many wastewater facilities are actually sending you samples?
And I'm sorry. I think I heard your question. I'm having some connection issues this morning.
I'm just wondering, is it a centralized facility for doing wastewater analysis by ddPCR, or is it distributive?
It's distributed. So, a lot of the main program in the United States is the CDC's National Wastewater Surveillance System, or NEWS as they call it. News currently is run by BioBot. I believe they're using RT-qPCR, but don't quote me on that. That's just my assumption. But basically, the news system, to my last recollection, covers about 30% of the U.S. population. So there are about 100 million people. But there are many, many more smaller projects that are funded through CARES Act funding that's been routed to state or local health departments and or other public institutions like schools, correctional facilities, nursing homes. I'm sorry, any type of congregate living facility. So, there is a very distributed effort. There's not one centralized laboratory that's running it, but there are a number of federal organizations that are trying to collect and compile all this data into one central public-facing source of information.
And is there a possibility that the funding for that is in jeopardy?
I talked to Amy Kirby a few months ago, and she said that the NWSS funding is secured until 2025. Amy Kirby is the director of the CDC NWSS program. So she had also told me that they're looking to integrate the wastewater surveillance funding into the annual CDC budget as opposed to the CARES Act COVID funding that was developed around that. But I think it's a little too early to say at this point in time. There's the value of wastewater surveillance has really been proven, but it really comes down to, I think, whose hair is on fire about the situation. What's the public health crisis that we're able to really solve through or provide data. We're never going to solve something through wastewater surveillance, but we provide near real-time data pertaining to that public health crisis. So, there's an infinite amount of applications of this science, of this, methodology to various human health concerns. But really, I think it comes down to, at one point, is it such a problem that we're going to see federal funding coming down to the state level in order to address it? And at that point, then it's a done deal. But we're in the field right now. We are really working hard on trying to secure the funding into annual budgets at the federal level, as opposed to these emergency budgets that have come up.
And the other part is that don't people want to do it for future preparedness or pandemics, right? Aren't you guys trying to put on like variants of concern or viruses and pathogens of concern? I heard is one thing that wants to be monitored throughout time, right?
Well, yeah, absolutely, Afshin. I mean, the CDC also, by the end of the year, supposedly, tentative timeline, they're going to be expanding the NWSS system to cover influenza, RSV, enteric diseases, other GI diseases, and antibiotic-resistant genes. So they're really looking to, expand that. And I believe that ultimately we'll see this the wastewater surveillance process integrated into the National Notifiable Disease Surveillance System. So that's, of course, the program at the CDC that oversees about 120 notifiable diseases, be they communicable or not. But I think it's pretty likely that we would see wastewater surveillance integrated into that program in the future. Now, what date that happens, your guess is as good as mine. Right. But, I do ultimately see that as being one of the nesting places for a very robust wastewater surveillance program.
Yeah, that'd be neat. Because COVID has shown us the benefits of it, at least. So whether people were paying attention to it beforehand, that was you. People like you were paying attention, but others weren't. Yep.
It's we were a fringe science until 2020. So, but yeah, the value's showing now. So it just comes down to one of the things is securing public buy-in. And I also think really increasing the utility of the data sets, because I have seen a lot of programs that ended up being data generation for data's sake. And, it's incredibly useful information, but if you don't have a good plan about, what are the stakeholders that are going to be using the data and how are they going to use the data, sometimes the wastewater data just becomes something that's filed in the round filing bin and nothing more happens from it. So, the COVID-19 was very reactive. and everybody jumped on board on this. And, I think some of the data didn't end up being used as robustly as it could. It really comes down to developing, that full experimental design and really getting the stakeholders around the table that will be able to leverage the data properly.
Great. Thanks, Adam.
Of course.
I think that wraps it up, but unless people have other questions, either for Adam or any other thing we discussed, your time.
Hi everyone.
Hey, Diego, go ahead.
So, I have a question about the figure that you showed before, the cases, the global cases of COVID in
This
ICU.
one?
Yeah, that one. I was just wondering, have you checked, like, since 2020, how is these plots compared to the ones at the beginning of the pandemic? So are they significant yet, or they are like very tiny?
Yeah. Sorry. Yeah, I the zoomed in version. I should show the other version. Yeah, I mean, if I had 2020 in here, you'll see like the peak here is a lot higher than this was the Omicron, right? Peaks. Those Omicron peaks out competed everything that was before that, so it'd be a lot smaller. And same with the hospitalizations, though. I have to go back. I don't remember. Some of it was comparable. Some of it was greater during Omicron. But yeah, I could show that next time.
Another thing that is interesting to me here is that there is an alignment between different regions around the planet, right? Like the US and Japan, or they seem, is this because of mobility? Just because people move across these countries?
Yeah, no,
They are
100%.
almost aligned, right?
Yeah. I mean, you can see there's a lag sometimes, right? You can see, well, Japan and South Korea, for example, new cases that they're aligned pretty nicely. But then, yeah, when you look at some of the things that happen, hospitalizations, you see that trend happen. A lot of times we see that little delay, right? Something earlier on in the pandemic, 2021, 2020. We saw usually something happen in Europe or UK. A month later, it was always in the US, and then a month later, it was always down in South America, where you're at.
Yeah.
So,
Okay.
but now things are aligning a little more than before. Yeah, definitely we see that happening.
That actually happened in the 1918 flu epidemic when the epidemic was first identified Fort Riley, Kansas, and then 2 days later it was found in Mumbai, India, and there was no way at that time that could have reached around the globe by travel at that point. So it must be some common factor.
Yeah.